Warm welcome to the last session of today about iron deficiency and heart failure. Please enter room. So we have today world-leading experts here in the room, actually, and also online. So I'm sure this is going to be a really interesting session. And my name is Karin Korovic Cabrera from Karolinska Institute at Södersjukhuset. So we will start with Dr. Shelley Syverud from Canada, who will summarize the evidence for now. Please.
Wonderful. Just noting that the timer says 20 minutes, not 10 right now. And it's very intimidating to be the first speaker when the authors of many of the papers I'm going to present are actually sitting at the table next to me as well. No doubt talking about iron right now as well. So here we go. 10 minutes to go here. And I also have to introduce the concept of iron deficiency because some of you may not be aware of the prevalence of iron deficiency within patients with heart failure. Iron, yes, it is an essential micronutrient. You can get absolute iron deficiency where your absorption is affected, but there's also functional iron deficiency as well that occurs in inflammation. And the standard definition, ferritin less than 100 or ferritin slightly higher with a TSAT of less than 20%. And I think there's a lot of discussion about this TSAT less than 20%. The prevalence of iron deficiency, even without anemia, is very high in patients with heart failure. And it is associated with a worsening New York Heart Association class, as well as reduced survival. In fact, iron deficiency is common regardless of ejection fraction. And you can see on this table of registries as low as an EF or mean EF of 26%, all the way up to a mean EF of 39%, very high prevalence of iron deficiency, both in chronic heart failure, maybe even slightly higher in acute decompensated heart failure. So it's very relevant to all of our practices. Now, for an example here is a recent state-of-the-art review, very interesting paper, which I had the privilege of handling as an AE at the European Heart Journal. And it came up with a very interesting figure on the mechanistic pathways of iron deficiency heart failure. Type 1 iron deficiency is that such that you can see the TSAT is very low. There's in fact a systemic depletion of iron. This results in progression of heart failure. In type 2, there is deconditioning and inflammation, which then targets skeletal muscle iron depletion, thus leading to worsening heart failure. And in type 3 iron deficiency, there is a very specific targeting of the cardiomyocyte, which leads to progression of heart failure. These are all very complex pathways. I think I need a cartoon to sort of visualize what all of this actually means. Here's the way I think of it, and we talk about targeted changes like mitochondrial dysfunction, apoptosis, results in the patient. What happens at the patient level? Impaired exercise capacity, reduced work efficacy, impaired cognitive performance, as well as associations with increased morbidity and mortality. So now we roll on to the clinical trial evidence up to 2024. I will not go past 2024 because that's going to be coming up in Stefan's talk as well. So we start off with some functional studies with IV iron in patients with heart failure with reduced ejection fraction as well as mildly reduced ejection fraction. And what we saw in these clinical trials was an improvement in various definitions of functional status, improvements in biomarkers in those patients randomized to IV iron, as well as improvements in patient global assessment quality of life. So what kind of recommendations do these, in fact, translate into when you do these types of studies? Well, and this is, again, before 2 studies. I'm going to show you next, AFFIRM and Ironman. This is where we started off with sort of a 2B, saying IV iron replacement might be reasonable to improve functional status and quality of life. These were short-term trials with a small number of patients. Let's go on to bigger, more robust clinical trials in patients with reduced ejection fraction and mildly reduced ejection fraction. The three on the left-hand side of this table include clinical trials with ferric carboxymaltose and Ironman enrolled patients to ferric dirosomaltose. You can see these studies include much larger patients than the functional trials. They're much longer in duration as well. And their primary endpoints aren't functional or biomarkers or quality of life. They're in fact, with the exception of CONFIRM-HF on the very left, these three are predominantly reductions in clinical events and heart failure hospitalizations. So the first two to come out were Ironman and AFFIRM, and then came HeartFit. So let's look at what happened with AFFIRM and Ironman, two bigger studies adequately powered for clinical events. I want you to look at the top portion of these Kaplan-Meier curves. Both of these trials just narrowly missed statistical significance is what they would say as they're being presented. There are risk reductions occurring, rate ratio 0.79 for AFFIRM AHF, and in Ironman, a risk reduction of 0.82, but confidence intervals crossing 1, and p-values were not significant. Then they do a COVID analysis as well, censored for COVID cases and pre-specified in Ironman as well, and they do hit statistical significance. And so this actually does, in part, impact future guidelines, this COVID analysis in both of these studies. Plus, they do a meta-analysis. If you don't get quite what you want, mix it up, put it in a meta-analysis, and see where things land. And that's what happened here with both ferric carboxymaltose and an Ironman, the other ferric dirosomaltose. And you can see that the use of IV iron in recurrent heart failure hospitalizations, cardiovascular mortality, actually was in favor of giving IV iron. This then impacts future guidelines, this type of analysis. And you can see the Americans were a little behind still, but the Europeans in 2023 did make a class 1 recommendation for improvements in heart failure symptoms and quality of life, and a 2A for the reduction in heart failure hospitalization in those patients randomized to IV iron. Next comes the HeartFit trial. This is, again, a longer trial, large number of patients. This is the largest number of patients randomized to a ferric carboxymaltose trial. And I think just clinicians want to know, how often do I check it? The visits for this trial were every 3 months, and the dosing was every 6 months. So some practical guidance there for you. And the primary hierarchical endpoint, including all-cause mortality, heart failure hospitalizations, and 6-minute walk, did not meet the regulatory pre-specified target p-value of 0.01 with a win ratio of 1.10. So again, you'll see numerically there are improvements in or reductions in death and heart failure hospitalizations and improvements in 6-minute walk tests, but did not meet that statistical threshold for being clinically significant. A lot of talk about perhaps why that happened, and I've just circled what might be the main hint as to why HeartFit didn't meet its primary endpoint, and perhaps it's because it had the lowest percentage of patients with a TSAT less than 20%. You'll be hearing about FAIR-HF2 very shortly. But again, if you don't quite hit your primary endpoint, what do? You do a meta-analysis and have a look at the overall benefit of a therapy in a patient population. And you can see here the AFFIRM, CONFIRM, and HeartFit, all which used ferric carboxymaltose, showed a significant reduction in the rate of cardiovascular and heart failure hospitalization, but did not reduce mortality rates. So I think what we're seeing is an evolution of heart failure guidelines. I will end. My second last slide is going to show you some good news here. Cardiologists are well ahead of nephrology in terms of recognizing the importance of iron deficiency alone versus iron deficiency anemia. Nephrologists wait for anemia to occur to treat iron deficiency or look for it in any way. cardiologists, we're ahead of the game. We're starting to look for it on our first clinician visits or first patient visits in clinic. I know I'm screening for iron, TSAT, and ferritin regularly in my patient populations as well. And this meta-analysis was a call to action for the nephrology community to recognize iron deficiency because of the potential significant event reductions which could occur. They're looking for their randomized controlled trials with iron in their patient populations with CKD. And this is my final slide. The iCardio Alliance is the most contemporary heart failure guidelines, which have in fact incorporated the data that Professor Anker is going to show you here and recommending IV ferric carboxymaltose or ferric derissomaltose in iron deficiency to improve symptoms as a strong recommendation and for reduction in heart failure, hospitalization, and cardiovascular death as a recommendation. You can get this on iCardioalliance.org website or go to Global Cardiology. Thank you so much.
Thank you very much for this excellent summary and excellent on time on the second spot. I just want to mention also we have another chairperson online, is Professor Ashok Kumar joining us from India. And now we go to the next speaker, Professor Stefan Anker from Charité Berlin, world-leading expert in this area, has led many landmark trials, so it's an honor to have you here. Please.
Yes, let me start by a funny remark. Whatever is the time and CO2 spent on coming here, I discussed with Gianluigi and said, why don't we make this a bit more efficient? So I speak longer. So per minute, it's less kind of whatever it is. And I'd say this already to the chairperson. We agreed on 15 to 16 minutes.
Okay.
Now, you see all these guidelines, and I show similar things that Shelley is saying for one or two cases, but make a completely different point. This guideline, when it came out in 23, ignored, although the data were already known to the committee, the HeartFit kind of statements. It ignored the meta-analysis that was coming out at the ESC. Rather unfortunate that guidelines sometimes intentionally ignore things just because of deadlines. And by the way, if you think about the 2026 heart failure guideline of the ESC, it will ignore everything that is not coming out by the 31st of December this year in peer review. So if you publish something at the ACC, it will be ignored by the guidelines. Now, the guidelines were informed by these previous meta-analysis, very successful results. I'm not showing it because of this, but I'm showing it because of these dramatic reduction in event rates, heart failure hospitalization, cardiovascular death, 47%. This is the reason how we planned. This data was the FAHF2 trial reason for kind of developing the program. We thought, okay, let's be half as good, and we planned for this. What we didn't think best really good enough about is that this was data limited to 12 months follow-up, and you will understand in a second why this is important. Then, of course, the Ironman study came out, and with Tim Freedy, we did a Bayesian statistic analysis. In Bayesian statistics, the most important result is actually the prediction of the next study. And you will see here a very wide confidence interval, and the HeartFit trial came in somewhere on the less than neutral, and that was predicted by the meta-analysis. Then we saw these TSAT interactions, and if you look in a second at the primary endpoints of the FAHF2 trial, you will understand that there was the thinking that this TSAT interaction really means maybe we should have a new definition of iron deficiency, ignoring anybody with increased ferritin and just focus on TSAT alone. And FAHF2 was the only trial ever done to actually test the idea that low TSAT, here also in this meta-analysis, shown to be strongly associated with the results of the treatment, could be beneficial. Now, Shelley mentioned TSAT levels being on the higher end. They were not on the higher end in the HeartFit trial, but on the very high end. Look, this is all the studies before HeartFit done, and not a single trial had an average TSAT of above 20. So what was HeartFit doing? The average was 24. I put it to you by modern criteria. I wonder whether 1/3 of these patients didn't even have iron deficiency. I don't know what they did. I can assure you these patients were totally different. So FAHF2 in comparison achieved what we wanted to achieve. The median of TSAT inclusion was 16.4. So in that sense, it was successful from what it wanted to do for the inclusion. HeartFit, you've seen, let's be very frank, even if you call this possibly kind of significant, not meeting the pre-specified p-value, but a win ratio of 1.1, and these events overall make for very little difference. This is the Kaplan-Meier curve for this study here. And tell me what you want, but this is close to nothing. But the reason is actually that the patients, Shelley said they got every 6 months they got a dosing, but they only got a dosing if they had an iron deficiency like at baseline. In other words, 80%, 90% never got a second dosing. The dose that they received was at the beginning, and then for 2 or 3 years they were left alone in most cases. We tried to do this a little bit different in FAHF2, and we succeeded halfway, unfortunately not full way. The study was done in Germany, most patients, and was done second most patients in Poland, a few other European countries. A few people involved are here on the podium, and I can also tell you that this was government funded 2/3, 1/3 was company supported, where Vifor not only gave drug, but then also additional funds, because as is common in publicly funded trials, they never plan for trials taking longer. They never plan for funds need to be bigger. And there's almost no trial in the world that comes up with the final result having the original budgets. That just doesn't exist. But governments don't think that way. So we had to get money from elsewhere because the COVID crisis came in the middle of this trial program in a very relevant way. We knew during the trial that many patients didn't get the iron in the second and the third year. We tried to push this as much as possible. We didn't know exactly how this was winning. So we thought maybe the whole idea of having these recurrent events that basically don't work if you stop the treatment. Only first events work with the first treatment. Recurrent events require recurrent treatment. But if you have a poor performance of recurrent treatment, you may need to do things differently. So you know that I'm a proponent of having multiple primary endpoints. We did this in the ReShape trial as well. So we did it here as well. And one of the primary endpoints was actually focusing on the patients with a TSAT less than 20. We were thinking that in these more vulnerable patients, we should have a particularly strong reaction. Let's see. And we were also thinking having recurrent heart failure hospitalizations, excluding death, that the death winning chance was the lowest. Therefore, we wanted to have one kind of additional endpoint excluding death. I can explain you later the Hochberg procedure, but it's a very valid approach. So we did this trial, the baseline characteristics, 70 years of age, men 2/3, but very well treated patients, hemoglobin 12.5 on average, ferritin 70 on average. As I said, the median was 16 for the TSAT, 18 for the mean values, symptomatic patients with systolic heart failure. Now a very important point, half and half allocated to treatment or placebo. And now comes the shock. Look at this, completeness of follow-up, 12 months of the original, you might say 1,100 patients after 1 month, we had already lost 10%. Of the original 1,100 patients, 600 at the end of 12 months, 390 at the end of 2 years, 200 only at 3 years. And the average follow-up, therefore, was much shorter on treatment than we were thinking. It's a 1.5 year follow-up in the trial. We hadn't really thought this through. Had we limited the trial at 3 years, at 2 years, at 1 year of follow-up, I will show you in a second, the trial would have been positive. We didn't do that. So what we did is we basically report here on several primary endpoints, p-value of 0.038, because in a Hochberg procedure, all 3 p-values need to be below 0.05 to win, or 2 of the 3 need to be below 0.025, or 1 of them needs to be below 0.0167. So here, 21% reduction of event rates at 12 months. Very impressive result, 29% reduction. but technically not significant for the total follow-up time. 20% reduction of heart failure hospitalization recurrent at 12 months, 35% reduction of heart failure hospitalization. But the totality here, the very bit beyond 36 months, you don't actually see here, that made the trial neutral. And here's the third endpoint in the TSAT less than 20 subgroup. The most significant result was this neutral result. The TSAT less than 20 definition does not work better than the original guideline definition, so we can continue to use it. Subgroups make no difference. All of this, no difference at all. The trial confirms that exercise capacity and quality of life and patient global assessment also are better. So here's the real problem. This is the dose all the trials give in the first year. 1,500 to 2,000 milligram. Look at this. We achieved 900 in the second year, but remember, that was only less than 50% of the patients anyway that were in the trial and got treated, and 700 milligrams in the 20 or 30% of patients available in the third year. The other trials, much less. So we were better than the previous trials. We were nowhere near what we have in the first year. The reason is, of course, the way you rule the continuation of treatment without going into the details. You can be liberal, very restrictive, like HeartFit, or somewhere in between. Very different rules. We have no precise idea how to guide the treatment. My private opinion, we should be very liberal. So what if we had stopped after 1 year like all the other trials? Look here at the p-values, 0.005, 0.009, 0.01. The patient easily would have been in the New England Journal, very positive result. 2 years, ReShape-HF2, we restricted at 2 years, like every device trial is restricted. Significant, easy sell to the New England Journal. Now, had we stuck with the original primary endpoint, which was this one, the total first and recurrent heart failure hospitalization CV death, and do the restriction at any of the time points at 1 to 3 years, win. The problem is the loss of follow-up time. The teaching for your future trials is restrict your drug trials, particularly when you have an IV infusion and particularly when you see loss of follow-up of these patients. Time restrict the follow-up. It's totally okay to do so. It's done in all device trials. Do it also in your drug trials. Much better chance. A drug is supposed to be given. Now, you are not allowed to do an on-protocol analysis, but you are allowed to basically time restrict the follow-up. The meta-analysis that was consequently done, the primary paper of FHF was in JAMA. We basically now did a primary endpoint assessment of the original FHF2 assessment, recurrent heart failure hospitalization and CV death at 12 months and for the total available follow-up. We analyzed all trials in the same way. Ironman published exactly how it was analyzed, and all the other 5 trials where we had the databases, we did exactly match the analysis. So very simple result. Overall, total duration of follow-up with the original primary endpoint that everybody wanted, 19% reduction, significant result on 7,000 patients. If you're restricted to 1 year where we give the treatment, this is very successful when you give the treatment, 28% reduction. Everybody wants to see the recurrent heart failure hospitalization, 22 in total reduction, 31% in the first year. And if you look at death, you notice 13% number? In the previous session, you saw SGLT2 inhibitor. The meta-analysis of all SGLT2 inhibitors in heart failure has exactly 13% reduction in CV death in the first 12 months, 18%. All-cause mortality is even 20%. One real interesting finding in this Nature Medicine meta-analysis was the subgroup of women. Don't forget, women get benefits for symptoms and quality of life, but for events, they seem not to get benefit. We need to figure this out more. Let me conclude that the FHF2 trial in itself was very consistent in its narrow miss to the other trials, but the totality of data is showing us benefits from the meta-analysis. The 20% less than 20% TSAT definition is not better than the guideline definition. It doesn't work. The women subgroups, we don't know. And yes, there are global guidelines, let's see what other guidelines next year and later come. Thank you so much.
Thank you so much for letting us behind the scenes and knowing some tips and tricks for future studies in this field. So now we have the next expert in the field. It's Professor Stefan von Healing from Göttingen. Please, Professor Healing.
Well, thank you very much. You've heard already a lot or quite a bit about iron deficiency in heart failure, and I will be covering HFpEF and iron deficiency. I will talk a little bit about the function of iron in humans, about our organ-specific iron regulation, of course, about the prevalence of iron deficiency and the treatment of iron deficiency in HFpEF. So very briefly about the functions. I think you've heard already a little bit about that. Well, iron actually has multiple functions, and that is probably one of the reasons why we do see a lot of benefit from the treatment, because mitochondria contain iron. Each of the enzymes of the respiratory chain, each single one of them contains iron and requires iron for proper functioning. This is true for skeletal muscle. This is also true for the myocardium, but also in the nervous system, neurotransmitter synthesis is iron dependent, or the production of thyroid hormones. We recently found that also bone mineral density seems to partly depend on iron, because one of the enzymes in the production or in the activation of vitamin D is iron dependent. The most important markers, of course, you've heard a lot about already, are ferritin, which is storage of iron, and transferrin saturation, which is the utilization of iron, with the most important enzyme or the most important protein to alter the uptake of iron being hepcidin. Hepcidin is an acute phase reactant produced in the liver, and it regulates ferroportin both in the gut but also in cells of the reticuloendothelial system. And with that, we have absolute and functional iron deficiency. Functional iron deficiency meaning that the iron is trapped inside the cells of the reticuloendothelial system. So organ-specific iron regulation, of course, we know about a little bit about that. We know there's a strong dependency of peak oxygen consumption and the volume density of mitochondria. The more mitochondria, the more exercise capability. And since mitochondria require iron, it is important that iron deficiency does play a role in this scenario. Now, why can iron treatment help in improving exercise capacity? This is because of the mitochondrial iron need, because what's happening here is that phosphocreatine is being shuttled outside the mitochondrium, and creatine then goes back without the phosphate group, and the phosphate is used for contraction. Now, we have seen that iron is dependent on the respiratory chain. So each of the enzymes of the respiratory chain requires iron. And one of the studies that was done by Obi Okonko's group in London, they looked at MR spectroscopy, and with which you can visualize the uptake of phosphocreatine and the shuttling of the phosphate group. Now, what they did is they treated patients of iron deficiency with iron, 21 patients versus placebo, and what they saw is that the phosphocreatine half-life was reduced, and this means that the shuttling of the phosphate group is becoming quicker, and this may be one of the explanations why patients can exercise better after treatment of iron deficiency. Now, coming to the HFpEF, the prevalence of iron deficiency has been examined quite a few times now. Of course, you know that iron deficiency is mostly in heart failure defined as a ferritin below 100 or a ferritin between 100 and 300 if at the same time the transferrin saturation is below 20%. Now, using these criteria, we have used the SICA-HF data that we collected as part of a European Framework 7 project, and we found about 190 symptomatic patients with HFpEF, that 111 of them had iron deficiency. This is 58% of patients. Now, data from the Swedish Heart Failure Registry also suggest quite a number of patients being iron deficient, both in HFrEF but also in HFpEF. If you look at the HFpEF patients here, you see that 60.8% of these patients had iron deficiency, and about 1/3 of these patients is non-anemic, 2/3 were anemic. So there's a high prevalence, it appears, in patients with HFpEF to be iron deficient. Some of them, about 2/3, are anemic, 1/3 being non-anemic. The need of iron to treat the iron deficiency in these patients, as you can see, is quite high. Approximately 55 or even more % of the patients required 1,000 milligrams of iron to replenish their iron stores. Now, through the treatment of iron deficiency in HFpEF, there's only one published trial so far, but several are ongoing. And I think many of you will know other trials that are currently being put together, and we sure will hear more in the panel discussion. However, the trials that have been performed with the last, which has been presented by Stefan Anker just in the previous talk, most of them, or all of them essentially, were either HFrEF or HFmrEF trials or both. So the trials that I could find on clinicaltrials.gov is the one, of course, that I will present to you in a second, which Stefan Anker and myself have done together, is a FAIR-HFpEF trial. Then I found the PREFER-HF trial, which is marked as completed in clinicaltrials.gov. It was done in Spain. And there is one trial, IRONICA, that is currently being conducted in the US. I think it is important to look at the different primary endpoints because this will have an effect whether or not the drug will show an effect or not. We use the change in the 6-minute walk test distance at 24 weeks, the same as true for PREFER-HF. If you take IRONICA, they use the same endpoint, but at 12 weeks. The hemoglobin threshold is also making a difference because there is in PREFER-HF, for example, no thresholds or no margins for the hemoglobin. At least I couldn't find any. For the iron deficiency definition, the guideline criteria were used in our trial in FAIR-HFpEF. In PREFER-HF, it's the same. In IRONICA, they only use the transferrin saturation below 20%. Of course, IRONICA is also a trial that recruits patients with HFpEF and HFrEF. And the randomization is either ferric carboxymaltose or oral iron. Finally, there are usually at least some NT-proBNP criteria. IRONICA, I think this is an interesting point, uses the BMI-specific cutoff. In our FAIR-HFpEF trial, we had an inclusion criterion of a 6-minute walk test distance below 450 meters to be included in the trial. And this might also be important because there is some possibility to improve the 6-minute walk test distance because it needs to be decreased at baseline. So the FAIR-HFpEF trial, which was published in the European Heart Journal last year, recruited patients with an ejection fraction of 45% or higher. There were several inclusion criteria for the left atrium, so an enlarged left atrium or an E over E prime of a certain cutoff, so an increased E over E prime. All these were parameters that were necessary, raised natriuretic peptides, and a 6-minute walk test distance below 450 meters, as I mentioned before. Presence of iron deficiency, according to the criteria, patients were then randomized to receive either placebo or ferric carboxymaltose, and the primary endpoint was the 6-minute walk test distance change after 24 weeks. And as you can see, there was a significant increase in the 6-minute walk test distance after 24 weeks, with the highest value achieved after 32 weeks, and the change here was almost 49 meters. And this is something that is deemed clinically meaningful. We have recently published an editorial in JACC Heart Failure commenting on another paper in which we discuss the need for redefining or reframing iron deficiency in heart failure, and possibly, and I'm sure we will discuss that in a minute, a transferrin saturation below 20% is an easier criterion for everyday life to be used to identify patients with iron deficiency. So more than 50% of patients with heart failure have iron deficiency. It is well possible that in HFpEF the numbers are even higher. The current definition, I've mentioned before, ferritin below 100 or below 300 together with a transferrin saturation below 20%. The guidelines tell us that this is independent of the heart failure type, so it can be used for HFrEF, HFpEF, HFmrEF. There is no differentiation in the guideline. Using TSAT alone may help identifying patients in clinical need of IV iron treatment, and iron deficiency is an important comorbidity, but I think we still do not sufficiently understand how to best diagnose this. Thank you so much.
Thank you so much for summarizing the gaps in evidence so far. So for the next talk, I think we have online Professor John Cleland from University of Glasgow, also a key expert in this field of iron deficiency and heart failure. So let's see if we can.
Can you
John
hear me?
Cleland? Yes, we hear you.
Yeah,
Please.
very good. So I'm sorry to miss you in Stockholm. Unfortunately, I wasn't able to travel, and I see we're running behind time, but I'm not sure I'll help you catch up. But let's have a go. So I've been asked to talk a little bit about what's next, and I have a list of things that might be what's next. Changing objectives, redefining iron deficiency. That's been discussed a lot already. I'll make my points. Meta-analysis, the use of oral iron, synergies between iron and other therapies that are in the heart failure portfolio, dose, and I might have a rather different view from Stefan Anker, that is, and also new trials, and I'll focus mainly on the new trials of HFrEF rather than HFpEF. So changing objectives. Just to remind everybody that there's been a remarkable success across the trials of IV iron in terms of improving symptoms and quality of life and exercise capacity. As Shelley's already noticed, there is a problem with the HeartFID study, and that many of us think that the majority of these patients didn't have iron deficiency, and we can't fix what's not broken. So pretty convincing, but should we be convinced by these improvements in symptoms, quality of life, and exercise capacity? And the answer is, I think that we can satisfy patients, and I think we can satisfy clinicians, and the trialists and the regulators perhaps need to think again. Well-being, I think, is the key target for patients with heart failure and their clinicians, and they have common sense. And the common sense is that if you're feeling better, this is usually associated with a better outcome. And this is an analysis from an old study, COMET, comparing carvedilol and metoprolol, where we looked at a thing called patient journey. So this was looking at the loss of notional life years, either due to impaired quality of life or to mortality. And a couple of important things to see on this slide. First of all, you can see that there was very little loss of quality of life due to the number of days these patients spent in hospital. And hospitalization was counted the same as death, so you got no points for quality of life if you were in hospital. So despite this severe categorization of hospitalization, it had remarkably little impact on the patient's overall experience. Intensification of diuretic therapy, likewise, not a huge impact. The two big impacts were on well-being and mortality. The longer you're followed up, the bigger the importance of mortality. But in the first 1 to 2 years, it is almost all driven by well-being. And in the Ironman trial, just to take a slightly different angle, we looked at all-cause hospitalization, not just heart failure hospitalization. And there was a significant reduction in all-cause hospitalization, which was driven both by a reduction in cardiovascular and non-cardiovascular events. And interestingly, if you look at all of the events in this study, you can see that there are more hospitalizations due to infection, many of them respiratory infection, than are due to heart failure. In this study, we classified patients according to the primary reason for hospitalization, but also where something contributed as a secondary. And Stefan could turn his microphone off because I'm picking up some noise from him. So you can see that, and iron improved both of these outcomes. And I think it indicates that there is an improved resilience amongst this population to whatever life throws at them, and reflects their improvement in well-being and symptoms. So redefining iron deficiency, well, back in 2016, we published this paper showing a strong relationship between hemoglobin, death. Each circle represents the quintile of distribution. You can see that serum iron, particularly strongly related to the prevalence of anemia. Very weak relationship to ferritin. But notice that in terms of mortality, it's the lower your iron, the lower your TSAT, the worse your outcome. But the lower your ferritin, the better your outcome. So you actually want to have a low ferritin. Patients with a ferritin less than 50 are going to do very well. So how should we redefine iron deficiency? Well, I think ferritin is a good marker of iron deficiency when it's less than 15, but this is hardly any patient with heart failure. And in heart failure, it's really a marker of inflammation rather than iron deficiency. And we should just stop measuring it for clinical purposes because I think it just confuses people. In terms of TSAT, it's highly correlated with serum iron, but there's a sting in the tail, which we'll come to. And there's some diurnal variation, just this caused by the diurnal variation in serum iron, but this is probably suppressed in patients with heart failure, so it's not such a big of great importance. There's an acute increase after oral supplements, indicating that indeed there is some oral absorption of iron. Oral iron is not nothing in patients with heart failure. TSAT is also inversely related to ferritin. So if you have a high ferritin, you'll have a low TSAT and vice versa. So if you have a very high ferritin and you have a low TSAT, your transferrin then is low, and you will actually have a ridiculously low serum iron. So think about that. And I think this is quite important. On the other hand, if you have a very normal serum ferritin, you'll have a high transferrin, and then it becomes quite difficult for iron to saturate the TSAT. So you may miss some cases of iron deficiency. But I think one of the great markers of iron deficiency is hemoglobin. And I think that substantial iron deficiency is really unlikely in the absence of anemia. You might have some mild defect in your iron markers, but if you looked at the whole body iron content, I think it would only be mildly reduced. I do think we have to look at the definition of anemia itself. The WHO definition of anemia may be too conservative, and maybe we should be moving it by about 1 gram per deciliter up for men and women. And that brings us to serum iron, which might be the best marker of iron deficiency, but we do need more data. This is an analysis, the IPD meta-analysis that was published back in 2023, and the Ironman ferric de Maltose study. Just want to highlight that if you select the right patients, the impact of IV iron is larger than the effect of an SGLT2 inhibitor in HFrEF. So we're talking about large benefits for the right groups of patients. Notice in the IPD meta-analysis, if your TSAT was above 24%, you had an increase in events. And in fact, there's an increase in mortality once your TSAT reaches a certain level. And actually, I think that TSAT greater than 35%, regardless of what your ferritin is, you may increase mortality if you give the patient intravenous iron. And for that reason alone, I think that we have to have a TSAT less than 20% as an indicator for the need for intravenous iron. The other thing I'd like to point out are the purple blocks. These patients actually don't respond very well in terms of a rise in hemoglobin to an injection of intravenous iron, but they do respond very well in terms of clinical events. And if you want to see a mortality reduction, it's the people with a high ferritin and a low TSAT who might be profoundly iron deficient. These are the ones who really get the big benefit. This is some nice data from the HeartFit trial where they've actually begun to unwrap serum iron. Serum iron turns out to be the best predictor of the outcome from intravenous iron. You can see that many of these patients had high serum irons and they were harmed by giving more iron, whereas the patients with the low serum iron got the benefit. So there are two ways to improve the effect of a treatment. One is to avoid treating people who might be harmed from the treatment. The other one, of course, is to focus on the people who might benefit. So doing one or other of these would be very beneficial. You've heard a lot about meta-analysis, so I'm not going to repeat that in great detail, but just to remind you, we have these two types of meta-analysis: trial-level meta-analysis and individual patient data meta-analysis. Stefan has shown you the conundrum of the male-female sex difference in the trial-level meta-analysis. Notice this is not seen in the individual patient data meta-analysis. Admittedly, the individual patient data meta-analysis doesn't include FAIR-HF2 or the Ironman trial, but I suspect that it will show the same. Now, the advantage of the individual patient data meta-analysis is that it adjusts for other covariates, which the trial level meta-analysis can't do. And I suspect that the reason why women don't benefit so much as men is that it's something to do with etiology. And we don't understand why there should be a difference in outcome by etiology with intravenous iron, but I suspect this is the driver. And just notice that if you have a low TSAT, these are the patients who particularly benefit. It wasn't statistically significant interaction in the trial level meta-analysis, but you can see that there does seem to be quite a difference between 0.77 and 0.96 in terms of risk reduction. Notice it's the people with the high ferritins in the trial level meta-analysis who tend to get more benefit. What about oral iron? I think most patients with heart failure do absorb oral iron. We've got an increasing number of studies that show that. It certainly improves your iron indices, it increases your hemoglobin, probably improves your symptoms, and it might eventually do everything that intravenous iron does. But many patients won't take their oral iron for all sorts of reasons. And if the iron deficit is large, then you may never adequately correct that with oral iron. On the other hand, I think there are legitimate concerns about IV iron. If you get the definition of iron deficiency wrong, I think you can give the patient iron overload, and I think that can be toxic. And there's also problems that myocardial regulation of iron seems to be independent of how the body regulates iron. And there is the potential for myocardial iron overload if you give repetitive doses of intravenous iron. What about synergies? Well, IV iron corrects iron deficiency quickly and reliably. Many patients do remain anemic. There's an erythropoietic defect. These are usually the patients with the high ferritin, the inflammatory profile. Notice that IV iron reverses the increase in platelet count caused by iron deficiency. So iron deficiency is a prothrombotic state, and that can be corrected by IV iron. And that might reduce thromboembolic risk. We don't have clear evidence on that yet. In terms of SGLT2 inhibitors, they stimulate red cell production. That will initially exacerbate iron deficiency, but eventually they cause a fall in hepcidin, the agent that blocks the absorption of oral iron. And due to the worsening iron deficiency and the anti-inflammatory effect of SGLT2 inhibitors, oral iron absorption probably is increased. And this will also slowly release iron from ferritin and increase GI absorption. But it takes time. Erythropoietic stimulating agents, they certainly stimulate red cell production, but they may exacerbate iron deficiency and may increase thromboembolic risk. And then we have oral iron, which may slowly correct iron deficiency. How should we put these together? Well, I think if you've got iron deficiency anemia, you have a large iron deficit, you should definitely get IV iron along with your SGLT2 inhibitor. And if you have a poor response, these patients often have end-stage kidney disease, consider an erythropoietin stimulating agent. On the other hand, if you have iron deficiency without anemia, I think it's a smaller and less certain deficit. I think there may be room for oral iron here, but if there's a poor response, consider giving intravenous. In the clinical trials, at least in the Ironman trial, it was only about 30% of patients who needed a top-up dose of IV iron each year. So these patients are not needing an awful lot of iron. Stefan might say they were underdosed, but we can debate that. And there might be a role for prophylactic iron depending on what the clinicians and the patient agree. In terms of dose, just to remind you that if you have a TSAT above 24%, you give IV iron, you're quite likely to increase the patient's cardiovascular mortality. I think that's the most important message from this lecture. These are the data from HeartFID, and you can see that many of these patients had, if given intravenous iron, had TSATs over 40%. And that is generally considered a marker of iron overload, hemochromatosis, and you might be wanting to reduce these patients' iron rather than increase them. So I think I feel that these patients, certainly in the first year in the HeartFID study, most of the patients were iron replete and many were iron overloaded. In terms of new trials, the one that many people are waiting for is the IVOFER-HF trial. This is a trial of HFrEF in patients with anemia and iron deficiency, and it's comparing IV ferric carboxymaltose with one or more oral iron preparations. Focus mainly in terms of improving symptoms and quality of life, but also hoping to look at heart failure events. And there's about 500 patients randomized in this trial. And then the big one that we're waiting for is the ICONIC-HF trial. It's just started this year, so it's probably only got a couple of hundred patients in it so far, but it is a fully fledged phase 3 randomized controlled trial. Aims to randomize around about 2,000 patients, taking a leaf out of Stefan's book, in that the follow-up is restricted to 1 year, but it will only be patients with the TSAT less than 20%. And I hope that we'll have no restriction on ferritins. I'd be perfectly happy to put patients with a ferritin of 1,000 into this study. So that's my talk. Thank you very much.
Thank you very much. And we open the floor for discussion. We're a little bit short of time, but we have like 15 minutes for discussion. And maybe I will introduce Felix Lindberg as a discussant, if you want to have a question first. And then please, the audience, feel free to go to the mic.
If there is nobody from the floor, I might ask about, I think in clinical practice, what sort of happens in the best case of scenarios is that you get screened, and in an even better scenario, you get screened and you're iron deficient and you receive 1 dose. And if you're even luckier, you get a repeat dose if you have an iron need exceeding a 1 dose administration. But I think it's very rare that you get a dose repetition that approximates even the most restrictive of iron repletion strategies, so the hard fit basically. So my question is, you touched briefly, Professor Cleland, on the role of oral iron. Do you think that there is a role for a hybrid strategy where you repeat with IV and then keep repleted with oral?
I think so. I think that should be considered. We don't know how successful that hybrid strategy would be, so we should be hesitant about jumping to conclusions. But certainly, in a situation where there is a problem about delivering repeat IV iron, then I think that we do see an increasing number of studies showing that there is oral iron absorption in this population. I don't think it's enough to correct a serious iron deficit, so I don't think it is a substitute for intravenous iron in terms of correcting the initial problem. But in terms of prophylaxis of recurrent iron deficiency, I think there certainly could be a role. And yeah, we'd love to see some studies. I don't think they have to be outcome studies. I think they just have to be studies that demonstrate that you maintain correction of the iron indices. And of course, find out if it's acceptable to patients.
Sorry, but John, just briefly, that was exactly the HeartFit trial. They basically every year reassessed the official iron deficiency definition, and they basically found nobody needed iron because the official iron deficiency definition wasn't fulfilled. That's why they had so little iron application in the second and the third year, and the result is nothing then.
Well, I think this result was nothing because they didn't have iron deficiency in the first place.
Correct, but if you that automatically means if you do an oral iron study and you want to persuade the world to use it, you do need to have outcomes. Just correcting of iron deficiency means nothing.
I'm just going to add here,
Okay.
Felix up a great point about making sure we have systems of care and algorithms when we apply evidence-based therapy in clinic. We saw some data on implementation. It's best when there are nurses involved and multi-care teams. You have to develop an algorithm for the administration of this repetitively, monitoring treatment effects, and communicating back to the primary care physician as well that your patient has iron deficiency, figure out why, or you can try.
Thank you. So we have a couple of questions, please.
Fantastic panel and wonderful talks. Maybe we are on the wrong road. I mean, we are all basing our diagnosis of iron deficiency on circulating markers. I mean, binding capacity, ferritin levels. Shouldn't we maybe look into tissue parameters? Is there a way actually to measure iron load directly in skeletal muscle in the myocardium? And is that potentially a way to better specify our patients in need?
Maybe there is, but actually, who cares? This treatment, when you use the definitions we have, improves exercise capacity, symptoms, patient global assessment of well-being. That's actually a good treatment. That's actually a good result. And John said that in the beginning. So the definition was developed. The definition was developed for improving exercise capacity and symptoms and quality of life.
And we'd have an even better outcome if we got rid of all those people with a ferritin below 100 who didn't have a TSAT less than 20.
John, maybe we can prove that point in the IPD meta-analysis, but But maybe actually, if you take the lessons from FAHF2, we could have had a better result if we just had truly continued the treatment, which we didn't do.
Fortunately, a very high proportion had a TSAT less than 20.
But John, the iconic, it's not ironic trial. Ironic or iconic HF?
Iconic. Ironic was Stefan von Haling's study. Iconic is the ferric Derisa Maltose study.
Trial, I'm sorry, you two things you jumped too short. You're pushing for low serum iron, but you were not able to persuade all our lovely colleagues to adopt that, unfortunately, which would have been nice. And second, the trial is only 1 year. It will work, no question. I mean, it will get then, the whole trial is not done to prove very much except for getting a regulatory approval, and it will get a regulatory approval. But do we, after this trial, know better how to treat iron deficiency? No.
Yeah, please, Professor Rossano.
Giuseppe Rossano from London. I have a question and a comment. The question is, since we see iron declining in the storage, so liver, spleen, and muscles, well before we see anything in the blood, don't you think that we should try to, and we give iron supplementation to improve mostly exercise capacity and quality of life, don't you think you should be giving it to everyone up to a certain level of hemoglobin? That is the question. The comment is on oral iron. John, and we absorb at maximum 20% of the oral iron you give, and the maximum you can give is around 200 to 300 milligrams. Because increasing over the 200 milligrams, you get the GI effects that basically limit tolerability. So actually, the mean absorption is in the vast majority of people, is between 5 and 10 milligrams. So with large discontinuation rates due to GI problems, even in those people with that take low iron load. So at 3 months, there is a 40 to 50% discontinuation. So how do you think?
Well, I think I said that if you have anemia and you have a large iron deficit, then you should have intravenous iron. I don't think there's any doubt about that. Question is, if you don't have a large iron deficit, and of course, every single algorithm for giving intravenous iron depends on what hemoglobin you have, because they accept that hemoglobin is a marker of the magnitude of the iron deficit. So, and sucrosomial iron and some of the more newer irons have far better GI tolerability. So I think these large discontinuation rates, I think they're unproven. They are possibly scaremongering. So I think that there is room, I think, for considering a hybrid approach. I accept Stefan's point of view that is correction of the iron deficit sufficient evidence that the oral iron would improve morbidity and mortality? Well, it looks like we have several head-to-head comparisons. I suspect they're not going to be large enough to prove that that a real difference doesn't exist, but we'll see. And I think that hemoglobin is a good marker of iron deficiency. We shouldn't just see it as a consequence of iron deficiency. It is also a marker of iron deficiency. And I very much doubt that you have a large skeletal myoglobin deficit without a hemoglobin deficit. I think that would be weird.
I don't think that's scaremongering, because if you look at the EPAR of the all oral iron products of the European Medicines Agency, you see that reported. You see that reported also in many of the SPC of the oral irons. So I think that those are data that are out there in the public domain. And you may get up to a higher oral absorption with the IV iron formulation taken by mouth, given together with the vitamin C, but then you cannot give it for more than 5 days and you absorb no more than 40 milligrams.
Well, that's what I'm saying. You can't correct a large deficit with oral iron.
Thank you for this very interesting discussion. We have just a few minutes. I would like to invite co-chair Kumar. Do you have some closing remarks?
Yeah, wonderful presentation, lots of insights. Just a question to Dr. Cleland. You mentioned that the role of ferritin is very limited. So do you really mean that ferritin should be stopped compared to?
Yes. Yes.
Okay.
Stop measuring ferritin and then things will become much clearer.
Can I actually emphasize this point that John is just making. In most jurisdictions in the world, ferritin costs about 10 times to 50 times more than assessing TSAT, which comes for free, more or less. And the global guidelines do explicitly make the statement that if you have a resource-limited situation or for whatever else, under other reason, like a dislike of ferritin, do not want to measure ferritin, that's totally fine. Use a TSAT less than 20 definition. That's no problem. The global heart failure guideline do say that.
Merry Christmas, Stefan.
I thought that was a peace offer.
It was indeed. Thank you.
Mark, we finalize this discussion. Thank you very much for all the experts joining us today.
Can I ask for a Christmas gift? The second, maybe not the first, but the second analysis of our IPD meta-analysis that I hope we can do next year should look at the iron dose given as a kind of time variable and the outcomes achieved. And you bet on higher doses not winning. I bet on higher doses winning.
Okay. 20 euros more?
No, a really good bottle of wine. And maybe a dinner with it.
Done.
Thank you.
Thank you very much. So now we have Gianluigi Savarese here to conclude the day, please.
So thank you so much, and I first of all thank you for joining us. I think it has been a long afternoon, almost evening, and so I thank you all for participation. Also to those who are online, and we are looking forward to seeing you tomorrow. We'll start 8:30, and for a very intensive day, but I'm sure you will get a lot from this fantastic faculty who is joining us. Thank you very much. Have a nice evening.